fractures, and having heard and seen a lot of very exciting injuries, we're now going to move to the humble patella, which all of us will have to treat at some point, I think, if we're on a trauma rota. So what I'm going to do is talk a little bit about some of the important anatomical considerations, move on to a brief consideration of the epidemiology of the injury, and then I'll talk about the treatments and the outcomes that we can expect. Most of you will be familiar with the anatomy of the patella, which has two major facets, the medial and lateral side, and a smaller odd facet. Some people divide these facets into another three, but most of us just recognize two main weight-bearing facets in the patella. Quite a bit of work has been done on patellar morphology, but from the point of view of fractures, this is probably not of great importance, and it's more relevant, I think, to management of patellar instability. What is important, of course, is the function of the patella in the biomechanics of the knee. And most of you will be aware that the key thing about the patella, which is the largest sesamoid bone in the body, is that it greatly enhances the lever arm of the quadriceps. And in fact, it adds about 30% in terms of distance to the lever arm of the quadriceps, which has a profound influence on the amount of force that the quadriceps then has to generate to extend the knee. So if you lose the patella, you will lose this assistance of lengthening the lever arm, which is one of the main reasons we like to conserve it. The blood supply is from the geniculate anastomosis, and it's pretty generous. It's difficult to devascularize the patella unless you do a fairly radical exposure or there's been a very extensive soft tissue injury. So they tend to heal fairly reliably. Moving on then to the classification of this injury, there are a number of classifications around, but most people tend to simply describe the morphology of the fracture, and the common patterns that we encounter are described here, which is a slide lifted from Rockwood and Green's recent textbook, and you can see that many of them are transverse, involved in the middle part of the patella, or inferior pole fractures. The other common variety we see are stellate fractures, which may be displaced or undisplaced, and less commonly perhaps, but still well recognized, are the vertical fractures. Just in a paper we published from our unit looking at the incidence of these, the humble patellar fracture constitutes about 1% of all the fractures that we treat at our institution. And the bulk of the ones that are displaced, I've illustrated here, and they tend to be either inferior pole, the middle of the body transverse patterns, the stellate ones, or vertical fractures. So these are the ones that we will end up operating on most commonly. Now, so far as the mechanism of injury goes, the majority of patients that we see at our institution have usually have sustained the fracture as a result of fairly low energy trauma. Usually it's a direct blow to the anterior aspect of the knee. Less commonly, the fracture may result from indirect force in a violent contraction of the muscle, and this is a bit more common in elderly osteoporotic patients. However, a proportion of them are seen in high energy trauma, particularly in head-on motor vehicle accidents, and it's these ones that are associated with other significant injuries. Mostly the patterns are transverse, stellate, or vertical, as I've indicated. Now, generally speaking, in terms of diagnosis, it's not a difficult diagnosis to make. Most of the time, the physical findings are pretty obvious, with a lot of prepatellar swelling, inability to straight leg raise, and a palpable gap usually between the main proximal and distal fragments. Where there's been high energy injury, you should be thinking in terms of other skeletal injuries, particularly in the femur itself. They're associated with femoral shaft fractures and injuries around the hip, such as femoral neck fractures and hip fracture dislocations and so on. So these must be looked for. Imaging is pretty straightforward. We don't need too many fancy CT scans or 3D reconstructions to diagnose this injury. The one thing I would say is that although they're pretty obvious to diagnose on plain radiographs, the extent of comminution with this method of imaging is often underestimated, and most of us have been in the situation where we get a pretty nasty surprise at the time of surgery when we find we're dealing with a considerably more comminuted fracture than we'd anticipated on the basis of the plain radiograph. But still, most people would make the diagnosis and plan for treatment on the basis of plain radiographs rather than more sophisticated imaging. Just a couple of things that are worth noting. The standard AP and lateral view, it's often easy to miss a vertical fracture, which can be difficult to see on the AP view because the patella is superimposed on the femur, and on the lateral view it may be invisible. Most of you will be familiar with the bipartite patella, which I've illustrated here, which is typically a superlateral in location, recognized by a well-corticated margin. But to the inexperienced eye, this is often diagnosed as being a patellar fracture, which of course it is not. Now, the aims of treating patellar fractures are to preserve the patella, re-establish the integrity of the extensor mechanism of the knee, and ideally go for excellent articular congruency. I'm pleased to say that we've moved away from this patellar clamp here, which was designed in the late 1800s and was probably a fairly uncomfortable device, it's safe to say, when applied to the patella in an era when anesthesia was not popular. So we've moved on to more sophisticated methods of treatment now, which I will go through. But there is still, of course, a role for non-operative treatment. A proportion of these injuries will be minimally displaced, and vertical fractures are also suitable for non-operative treatment. So here's a couple of examples. This inferior pole fracture, minimally displaced, can be treated with a period in a cast or a knee brace. Similar to this fracture here of the superior pole in an osteoarthritic knee, again suitable for non-operative treatment as it is absolutely minimally displaced. And the results of non-operative treatment are pretty good. In the majority of patients, we can expect an excellent outcome as illustrated in these papers. The main thing to know about these injuries is that there is a risk of displacement in the first 2 to 4 weeks, and they should be carefully followed up during that period with radiographs to detect that should it occur. Now, if you look at operative treatment, which is what we will choose to use for displaced fractures, and look at the literature, you will find a bewildering array of operative techniques, mostly involving wiring techniques of one sort or another. And most of them have something to recommend them. However, generally speaking, the tension band wire with supplementary Kirschner wires or with cannulated screws is what most people would now prefer to use for management of the majority of these injuries, and it is supported on the basis of the published data and biomechanical studies in the literature. Many of you will be, or most of you I hope, will be familiar with the tension band wire principle, where the tension band wire applied to the external aspect of the patella converts the tensile forces here into compressive forces at the site of the articular surface, and usually is a way of getting these fractures to reliably heal. The technique is straightforward. We place 2 Kirschner wires across the fracture, and then a figure-of-8 tension band wire, preferably with 2 knots, one on either side, is then used to carry out the tension band construction. Important, of course, to get good lateral quality views during the procedure, so you make sure that these wires are out with the joint itself. So here's an example of that. One of the things about these tension band wiring systems is they do tend to cause a lot of soft tissue irritation, and this can be minimized to some extent by bending the wires at both ends and making sure that they're not too prominent, and as illustrated in this technique here. And some people use 4 wires rather than 2, so they can more easily bend the wires and impact them into the patella to minimize the amount of soft tissue irritation which occurs. As I've mentioned, there is evidence that using them in conjunction with cannulated screws, as illustrated here, is biomechanically preferable, but there is some practical limitation in using this technique, particularly when the fracture is more comminuted, where the method may not always be possible, but it has been reported with very satisfactory outcomes. The problem that we often encounter, of course, is that many of these fractures are somewhat more comminuted, and under these circumstances, then these more complex fracture configurations often require mixed modalities of surgical treatment. So this is a fairly comminuted inferior pole here, and as you can see, we've used a standard tension band wire technique, but supplemented with a simple cerclage wire around the patella. A simple cerclage wire on its own is not really desirable because it doesn't provide enough biomechanical stability alone to maintain the reduction, but in combination with the tension band wire is a useful adjunct. Again, another example with a very comminuted inferior pole here, and rather than excise it, we've done a combination of things here. You can see there's a tension band wire, there's a cerclage wire around the patella itself, there's a screw fixing one of the main fragments and a lag screw combination, and because the extensor mechanism was a bit tenuous, we've used a cerclage wire to protect that as well. So sometimes we have to use quite a variety of techniques to obtain the best results. Now, post-operatively, most of these patients can be managed with a cast or brace. I will usually opt for some kind of functional bracing system if I'm happy with the fixation, but a plaster cast in the first 4 to 6 weeks may be preferable if the bone is osteoporotic or you're not entirely satisfied with the integrity of the fixation. Now, a couple of special examples. Lower pole fractures are amenable to other techniques. This basket plate was described in a couple of papers in 2004 and 2005 with the idea that you can mold this onto comminuted inferior pole fractures and it avoids the need for having to excise it. And the fins of the plate allow the integrity of the patellar tendon to be maintained. These were reported in these papers to be associated with better results than excising the inferior pole, which is often an attractive option because it has the advantage of simplicity, but it does tend to result in patella baja with a lowering of the patella, and this may result in patellofemoral pain or stiffness in the post-operative period. I was asked to address the role of arthroscopy. Well, the role of arthroscopy in the management of these fractures in my own practice is absolutely nil. I do not use it at all. I do a lot of knee arthroscopy, and I'm quite happy with the technique for many orthopedic conditions, but I think that here in patellar fractures it probably has a very limited role. It may have a role if you're wanting to investigate a fracture that appears to be minimally displaced, but you want to be certain that the joint surface is congruent. But to treat a fracture like this arthroscopically would be technically very demanding. You have to bear in mind that the whole joint is open, you can't contain fluid within the joint. And what we're aiming to get here with articular fractures, as with any other articular fracture, is a perfect anatomic reconstruction of the joint surface. And I think that by open surgery you can do this more reliably. Also, open surgery is going to be a lot easier to deal with fractures when there's marked displacement or comminution. Another variety are sleeve avulsions of the proximal or distal pole where there's very little intact bone, and really these are situations where standard internal fixation may not be possible, and they should be really treated as extensor mechanism disruptions, and it's usually a soft tissue repair that's required in these situations, but suture anchors may be useful. The other alternative, of course, for comminuted segments is a partial patellectomy, and certainly small fragments of the patella can be removed and discarded without worrying too much, because as long as you conserve about 75%, it would appear that the effect on the biomechanics of the knee is fairly minimal, and good results have been reported. Usually, if you're excising an inferior pole, then you've got a soft tissue repair to reconstruct the patellar tendon onto the main body of the patella, and in this situation, cerclage wire is required to protect the extensor mechanism repair. The general goal in partial patellectomy, of course, is to preserve as much as possible, because it looks from the literature that as you know, you might expect, the more you excise, the worse the outcome is. Overall, the results of partial patellectomy have been pretty good, as in this paper published in 1990, where almost 80% were good at excellent, had a fairly lengthy follow-up. But Bosman did note in an earlier paper that once you start removing larger volumes, then it tends to be associated with a somewhat poorer outcome. What about total patellectomy itself? Well, of course, this is now regarded as an absolute bête noire and the kind of operation you must never perform. But I've certainly performed this on a number of occasions in my practice, and actually, I think it's not quite as bad as people would make out. There are many theoretical reasons for not wanting to get rid of the patella, as will be evident from my previous remarks on its importance in terms of biomechanics, because obviously you will reduce the extension power of the knee, you may get an extensor lag, instability, and effusion, and other biomechanical abnormalities that may result in the longer term in an increased risk of post-traumatic osteoarthritis and a difficult knee arthroplasty in theory at a later stage. But if you look at the published results of patients who've had patellectomy for complex patellar fractures, about 72% of them are reported to be good or excellent. So the majority of patients can expect a reasonable outcome. And we've all had the situation of having patients walk into our clinic with an x-ray that looks like this, sometimes decades after a patellectomy, who've had many years of fairly satisfactory knee function. So it's not something that I would advocate, but it's something that if you have an unreconstructible patella, it may be preferable to patellar conservation. You have to bear in mind that excising the patella, of course, may result in relative lengthening of the extensor mechanism, and some form of imbrication of the quadriceps mechanism may be necessary to avoid problems. If we look overall at fracture outcomes, one of the problems is that many of the series are small, but the common problems are loss of motion and stiffness from prolonged immobilization. This can be minimized by going for early motion. Infection rates are about 3 to 10%. Loss of reduction is not uncommon and has been reported in about 20% of cases. A lot of this is due to technical error. And again, there's a high incidence of post-traumatic arthritic change. Just to show you a couple of examples, this fairly unorthodox means of fixation here, you can see, was never really all that stable, and predictably it failed to maintain this rather comminuted fracture. So attention and to technical aspects of fixation are important. Like this one here on the left-hand side, you can see there was a gap at the time of the fixation resulting in a non-union at 6 months, as illustrated on the right-hand side. So you need to get the fractures compressed, or there's a risk that they will not heal. Again, one of the commonest problems with the standard methods of tension band wiring is that it's painful, and especially if you leave it as prominent as this, you're going to find a high requirement for removal. Now, just to finish off then, the problems in assessing outcomes are the range of good to excellent results varies from quite low at 30% to 80%, and the reason is that a lot of these are about repair constructs rather than fracture patterns in the series. Many series have small numbers, short-term follow-up, and we really lack good, large clinical trials in this area that would inform our clinical decision-making with a better evidence base. And that's something for the future, perhaps. Just in summary then, non-operative patellar fracture is suitable for non-operative treatment. Displaced operative treatment is definitely required, and tension band wiring remains the gold standard at the moment anyway. Cannulated screws where possible and patellar preservation techniques should be adopted, with the aim, of course, of good articular congruency. Partial excision and patellectomy does have a small role to play in very comminuted fractures. Thank you very much for your attention.
Thanks, John. We just have time for one question.